Hello everyone, I'm Dr. Guillaume Grzych from Lille University Hospital. I have nothing to disclosure. And this is first part of the video about the clinical chemistry and NAFLD. And in this part, we focus on biomarkers and hepatic fibrosis. So some remind about NAFLD. The progressive disease encompasses several stages, NAFL, Nash, and fibrosis. And in this third video, we focus on hepatic fibrosis. So in hepatic fibrosis, there are a lot of available markers and combination of marker scores to determine and be able to know if patient could have or not fibrosis. So at the beginning, we had to focus on the pathophysiology. To be able to choose the good biomarker is necessary to know the pathophysiology. For the liver fibrosis, the etiology of liver fibrosis can be variable, multiples. You could have chronic liver disease related to virus, to alcohol, to autoimmune, and also to NAFLD. You have an inflammation, inflammation in the liver with activation of some cells. You have release of cytokines, pro-inflammatory signals, and this process activates some cells called the hepatic stellate cells. Here we can show the activated HSCs, and this cell promote the fibrosis with synthesis of collagen, for example. So as we see here, we have a lot of potential biomarkers, pro-inflammatory biomarkers, biomarkers related to collagen synthesis, for example. For the diagnosis of liver fibrosis, you could use also imagery. You could use elastography techniques if you can measure the stiffness of the liver. But is very costly and the availability could be poor in your hospital or your department because you are necessary to have a device for the patient. It's not one device by patient. So it could be interesting to have biomarkers in blood. So there are a lot of potential biomarker, combination of liver biomarker, inflammatory biomarker, collagen, fibrosis biomarker. So there is a very recent paper published by colleagues, specialists in NAFLD. They write this review about the non-invasive technique of liver fibrosis in NAFLD. So I take some information in this paper. I invite you to read entirely this paper published by my colleagues. So the first potential combination of markers could be used is the AST-to-ALT ratio. This is a true transaminase, could be used in liver disease. You have to remind that these two transaminase is not specific of liver disease. You have the ALT is more specific of liver than AST. For example, AST could increase in case of hemolysis. So it's important to measure the two transaminases, but to make a ratio between the transaminases. Indeed, when you have higher elevation to ALT compared to AST is more specific than the liver, than other cause of elevation of transaminase. So here you can use this ratio when you measure transaminase on the patient to be able to make the difference between the cause in liver and the cause is not the liver. If you have, as you can see here, a score of the ratio very high is related to an extrahepatic cause. Cause here, the AST is more higher than the ALT. So ALT is secondary maybe. So you have to looking for another cause. When you are a score around 2, it could be related to hepatitis, to maybe NAFLD or fibrosis. But here, as you can see in the paper published by our colleagues, we are insufficient data for the use of AST-to-ALT ratio to make the diagnosis of fibrosis for you are here an area under the curve around 0.6, but without good external validation. And you could have also false positive in patients with normal ALT2. So it's not very good to use transaminase. Indeed, even in case you have more severe patient, the transaminase decrease. In fact, indeed, when you have fibrosis, you have less cells, less hepatic cells, so you have less enzyme cells. So it's not very good in more severe stage of NAFLD. We could use also the FibroTest. Is again a test developed by the Society Biopredictive with the same markers as previously described. So give you the list of the entire components is the same in the part 2 of this series of video. And he combined with a secret algorithm. You have to pay to have the result. And the performance is around 0.774 for FibroTest compared to histological tests. Higher the FibroTest result, higher the severe in histology patient you have. So 0.7 could be good if you want, but remember you have to pay, you have to measure a lot of parameters here. So there are another score could be very interesting in hepatic fibrosis. This is these two scores, APRI score and the FIB-4 score. And these scores use the transaminase and also platelets. Why platelets? Because liver is involved in the platelets synthesis with an increase of the TPO leading to synthesis of platelets. So when you have issue with the liver, you have potentially a decrease of the platelets numbers. And in terms of performance here, with external validation, we are around the curve of 0.8 for the FIB-4. So it's very good compared to FibroTest. Remember, the performance is around with external validation of the 0.7. So it's pretty the same, maybe better, but it's very easy to measure, easy to calculate. You just need the age, transaminase, and platelets. Remember, before that, we need apolipoprotein, haptoglobin, and other. And here, you just need 3 biological parameters, or 2, because in more the case, the transaminase is measured together. So just 2 measurements here at the age of the patient with good performance. So the FIB-4 is recommended from societies such as the EASL Society in Europe to screen the hepatic fibrosis in some patients. So this is a recent paper published by our colleague Laurent Castera with the use of FIB-4 for patients with suspected NAFLD. Remember, you don't have to perform in global screening population. You need to have specific patients. This kind of score is not demonstrated to have good performance in general population. You have to pre-screen your patient with clinics, with etiology. So in the first line of primary health care, you could use a FIB-4 here with specific cutoff depending of age to be able to have patients with low risk, with the FIB-4 not elevated number. So you can use modification of lifetime exercise to be able the patient have a better clinic after that. And you could repeat after 1 year the FIB-4 to reevaluate biologically your patient. If you have a FIB-4 with high number, it could be patient with risk. And at this time, you could get the patient to the hepatologist. So with this first line test, you could orientate your patient with a specialist hepatologist, and the pathologist could make transient elastography, for example, to be able to measure the fibrosis in the liver. So it's a good combination, it's a good screening here for the patient with suspect NAFLD. So FIB-4 is very useful and recommended by society, liver society. So another score is recommended also by a liver society It's called the NAFLD fibrosis score. It uses more parameters such as the FIB-4. You have here age, BMI, glycemia, diabetes, transaminase, platelet, albumin. And as you can see here in the external validation, who compare patients with low fibrosis and high fibrosis, you have a better performance of NAFLD compared to APRI, but seem the same as FIB-4. But it's good too. It's a free score, so maybe you can combine the two scores to have the same determination if you want to be sure if your patient has to go to the hepatologist. So it's a good score, also okay with liver society, recommended for liver society. There are also another score in the literature called the BART scores, could predict the risk of advanced fibrosis in NAFLD patient. It uses the BMI, transaminase, and diabetes in this algorithm, and it shows less performance than the other scores. As you see here, this is a paper with high performance level. It's be great to have maybe more patients, but this paper, you could see here the bar scores is a historical bar score. It's less performance than FIB-4 on NAFLD fibrosis score. So here's a combination of all the score we discussed here. So I recommend to use FIB-4 or NAFLD fibrosis score on the primary health screening, but not for all patients, because if you have a lot of patients with no specific indication, the performance is not evaluated for now. So we don't know if it's good or not to evaluate global screening population. There are also another scores in literature called the ELF scores, the Enhanced Liver Fibrosis scores. It uses a combination of biomarker for the fibrosis process with collagen, for example, hyaluronic acid. You have here the inhibitor of metalloprotease 1, amino terminal propeptide of type 3 procollagen is related to processes of collagen and fibrosis synthesis. And more you have an elevation of ELF score, you have the risk to have the patient with high level of fibrosis or cirrhosis. And performance is pretty good here with an area under the curve around 0.83 with meta-analysis. The meta-analysis about the validation of this score is pretty good for the fibrosis. But the major issue is the availability of the markers. Here you are markers could be very difficult to measure in laboratory. Is not included in, for example, in big automatic analytical device. So you need to have a specific lab in your hospital to be able to measure that. So it could be difficult for some screening and availability. So to summarize the use of these scores, it depends also in prevalence of the NAFLD and the fibrosis on your specific population. So it's different between the primary care and hepatology clinic. As you see here, the performance of non-invasive markers depend on the prevalence. It's not the same. So as I say, I don't know for now is this marker it's good for the general screening. We consider that to focus patients, to discuss with clinicians, to discuss with specialists in diabetes and hepatologists, to have a good already pathway for the patient. So to summarize, we have lot of biomarkers in the total stage of NAFLD with lots of different combination of scores. There are some markers could be involved in the statosis, but both with the Nash or the fibrosis. So it's important to have the good combination of marker. You cannot use isolated blood marker. This is a very complex disease with complex interpretation. So the perfect biomarker is not easy, is never exist. You have to make score in combination. Unfortunately, this score is not perfect. Is according to the patient, is according to the moment, is according to the etiology of the disease, and it's very, very important to discuss about the diagnosis with other specialists, is collaboration between specialists, the interdisciplinarity of the NAFLD issue. So thank you for the attention.